Firstly, I would like to thank the organisers and the chair for inviting me to this excellent meeting in such a wonderful city. It's my pleasure and honour to meet Giovanni and have the opportunity to debate this important issue with him. And in the process of this, hopefully helping increase your understanding of the issues involved. I'm going to talk a little bit about what we know about urinary tract infection, what we know about reflux, some views on congenital versus acquired scarring. I'm going to remind you about the theories of the mechanism of scarring and then look at prophylactic antibiotics in the management of reflux. And then I'm going to try and pull it all together by showing you some cases which I hope will convince you that reflux is important, that we should test for it, and that when we find it, we should actively manage it. Urinary tract infection is very common. It's the commonest bacterial infection in children in the UK, affecting 2 to 3% of girls and of boys and 7 to 10% of girls. It's primarily an infection of young people. Oh, sorry. I'm looking for the spot. It's primarily an infection of young children, particularly in boys. Everybody agrees that the acute illness should be treated, but then the dilemma arises. Who do we investigate? And it's you that have to make that decision. You all see urinary tract infections. You have to decide how you're going to manage them, how you're going to investigate them, and which guidelines, if any, you're going to choose to follow. If you look at it from the UTI point of view, most recover with no sequelae. If you do decide to investigate, then you'll find that about 5% of children with first UTI will have scars, and about a third of infants with UTI will turn out to have vesiculouriteric reflux. But and very, very few children will have very severe scarring. If you look at it from the opposite point of view, though, from the renal failure point of view, you'll find that 10 to 15% of end-stage renal failure is associated with reflux nephropathy, and that data is just generalised from registries worldwide. So, why might you want to investigate? Well, to identify a high-risk group, but without over-investigating those who are normal. We want to find out who's got an abnormality, reflux, some structural abnormality of the urinary tract, obstruction, dysfunctional voiding and abnormal bladder emptying. We want to find out who's likely to scar, the aim, of course, being to prevent scarring. We want to find out who's already got scars, the aim being to prevent the complications of hypertension and to prevent further scarring. Let's have a little think about scarring. There are two different views on this. One camp thinks that most scarring and defects are congenital. The evidence for this is that most children who have scars, you will find those scars when you first investigate them following a urinary tract infection. There is also evidence of renal damage in babies who've never had a urinary tract infection, and in fact you can see that kind of damage on their antenatal scans. So, if all scarring is congenital, then there's no point in investigating them because you can't prevent it. The opposite viewpoint is that most defects are acquired. Defects are sometimes not present at first imaging, but are present at later imaging. You can see scars developing in previously normal kidneys. You can see worsening of scarring. The history of urinary tract infection is important because the history of a first urine infection often isn't the first. We see more scarring is seen more in girls than boys. And if you think that they're acquired, then the link between urine infection, reflux and scarring is a causal link. And the important thing is that if you believe that, then there is potential to prevent scars. So what do I think? Well, I think both of these things. I think that there is good evidence that some lesions are congenital, especially those associated with severe reflux in boys. However, I also think that most scars are acquired from urinary tract infection and reflux, and those are the ones that could be prevented. So let's just recap what's known about reflux. Well, a lot of things are fairly well accepted. It's an inherited condition, it's congenital, and most resolves in childhood. It affects around about 1% of the population, but if you take the population that's had a urinary tract infection, it affects 30%. There's a very wide spectrum of severity, may not even be just one condition. At the severe end, severe grade 4 to 5 reflux, often bilateral, tends to be associated with quite severe congenital renal developmental defects and is found in boys. Most reflux is mild to moderate, and that's found primarily in girls. We know that statistically reflux is associated with scarring, but we also know that you can sometimes see scarring defects on DMSA after a urine infection, but where there's no reflux seen. What's known about scarring? Well, there's quite a body of evidence showing that scarring is associated with younger age of patients, with recurrence of urinary tract infection, with reflux, and with delay in treatment. And that severe scarring is associated with, I'm so sorry, pressing the wrong button for the light. Severe scarring is associated with a worse outcome. So what's the debate? Well, the debate is about the precise role of reflux and UTI in scarring. Is reflux simply a risk factor for pyelonephritis, and how much scarring is acquired and how much congenital, and can we actually prevent it? I'm just going to remind you about the mechanism of scarring. Most of what we know about scarring is from Philip Ransley's elegant piglet model. What they did was they surgically induced unilateral reflux in piglets, and then they infected the urine in half of those piglets. And what they found was that if there was just reflux or just infection, then there was no scarring. But if there was reflux with infection, then consistently the kidneys developed scars in a segmental fashion with adjacent areas unaffected. Those scars were particularly at the poles of the kidneys and were histologically and morphologically indistinguishable from the sort of scars that you see in human kidneys. What he found in the scarred components were that those segments had compound papillae like these rather than simple papillae, and those allowed passage of bacteria into those affected segments. The time to scarring was very short, 2 or 3 days. Now this study has been identically repeated in adult pigs by my colleague Malcolm Coulthard, and in fact these pictures are from his adult pig study. So what does this mean for children? Well, we know that about 70% of human kidneys have at least one vulnerable papillus. And this is a cystogram in a child showing intrarenal reflux through those vulnerable papillae. Is this replicable to children? Well, pigs have multiple vulnerable papillae, but they don't naturally get reflux. Children have fewer vulnerable papillae, about 70%, but some of them also have reflux. It's of evolutionary interest that there are no mammalian species who have a high incidence of both vulnerable papillae and vesiculoureteric reflux. We have observations from animal studies, from clinical observation and from transplants that kidneys can scar at any age. But that's a bit odd because actually most new scars are seen in the very young. What's thought to happen is if you're born with reflux and you have vulnerable papillae, there's a very high risk of urinary tract infection, and most children will scar, particularly if diagnosis and treatment's been delayed. I've already said 70% of human kidneys have at least one vulnerable papillae. We know from a study we did in the northeast that about 3/4 of all urine infections in under ones are missed in primary care. So if you've got 1% reflux and 70% vulnerable kidneys, you would expect a scarring rate of 0.7%. In Newcastle, we find that nearly 6% of girls referred with their first UTI have scars. This is our investigation strategy, which I won't go into in detail, but we're pretty active in investigating. So why are we standing here debating? Well, opinion has changed. In 2007, NICE in the UK and other organisations worldwide have started producing guidelines which recommend a much less intensive management structure of investigating very few children and managing them less intensively. Why has opinion shifted? Well, I think it's to do with this belief that focal parenchymal defects are congenital, the belief that reflux doesn't predispose to UTI, which is quite clearly wrong, and the fact that there is evidence that there's a lack of complete consistency in this relationship. We haven't quite worked out what the relationship is of urine infection, reflux and scarring. The problem is that this lack of evidence means that guidelines are based on the opinions of the writers and the evidence they use and the questions they asked. So going back to the NICE guidelines, they admit that most of their guideline is based on consensus. That's the consensus of the guideline writing committee. Giovanni and I would write very different guidelines, and I'm sure we don't have consensus in this room. The areas I've marked in red are the areas which are simply consensus-based. So quite a large amount of the document is not evidence-based because the evidence doesn't exist. We'll move on to management of reflux. I've got no time to talk about surgical versus medical management, and we're focusing on antibiotic prophylaxis. Older studies and case series which supported the use of prophylactic antibiotics have rightly been questioned by a number of recent studies. There were 6 main studies done in recent years which look at the effectiveness of prophylactic antibiotics. They vary in their entry criteria of degree of reflux, some of them excluding the more severe ends. Mostly they're quite small. The only studies which showed a benefit to prophylactic antibiotics, this French study showed a benefit in boys with grade 3 reflux, in which they reduced the number of recurrent infections. The Australian study here showed a small beneficial effect in all groups, and the Swedish study here also showed some benefit in some groups. But to be honest, the jury, I think, is still out on prophylaxis. Why might they fail to show a benefit? Well, most of them are too small. You need a much bigger study to show a reduction of, say, 10% in the number of UTIs. The inclusion criteria are variable. Compliance is an enormous issue. Some of those studies address the compliance issue, but we know compliance with long-term medication is poor in all groups of children. There's a lack of blinding. There was only one of those studies was placebo-controlled and blinded, and they vary in how they diagnose urine infection. I think that the management of reflux should not just involve prophylactic antibiotics. There is other management which is important. Education and awareness, managing dysfunctional voiding, rapid access for same-day diagnosis and treatment of urinary tract infections. All current management strategies are based on clinical experience and belief and not currently on evidence. I'm going to end with a couple of cases which I hope will show the point. We found these 3 children with vesiculoureteric reflux and these DMSA scans, and we looked at them and thought, that's really severe scarring. Surely this must be congenital scarring. But we found, I'm sorry, I don't know what's happened over there, but we found that these children had presented with a previous urinary tract infection and had these DMSAs after those infections. The difference was that they were very young when they presented here, and they were treated very, very quickly. Were they 3 unusual cases, well, we looked around the region and we found 20 cases where there was severe scarring shown on DMSA following presentation with urinary tract infection in children who had had a previous DMSA done. So these scans were done after their first urinary tract infection and these scans after their second. And you can see a clear difference. So what was the difference between scan 1 and scan 2? Well, they were younger, they were much more ill. Lots of these presented with febrile convulsion, got rushed to hospital. After scan 2, they were much older, not very unwell, and the time to treatment was much longer. So, yes, we failed to prevent scarring, but I would argue don't give up because it's a hard job to prevent scarring. I think we can prevent scarring. We need to reassess the problems and use a different approach. So I would say that following a febrile urinary tract infection, you should thoroughly investigate children. Those with VUR should receive prophylaxis, but they should also have active rapid management as well. Thank you. Thank you very much, Giovanni. It's a great pleasure to hear the case presented in such an erudite way. And I think I've got to start off by saying, actually, I agree with an awful lot of what Giovanni has said. I think possibly where we disagree is on how we will manage the situation. I already explained to you that I also, like Giovanni, think that there are two groups of children with renal defects which are seen in association with vesicular-ureteric reflux. There are those with the congenital abnormalities that you see with the very severe end of reflux, the grades 4 and 5, and particularly the ones affecting young boys. But I think that you shouldn't forget about the other, much larger group of children who have a much lower grade of reflux. For the boys with the congenital dysplastic type abnormalities, there is little that can be done to prevent that renal damage. You can prevent further damage to it, but there's nothing you can do about the congenital abnormality they have. But I think it's really important not to forget about those sorts of cases that I showed where the children presented with urinary tract infections with clearly normal kidneys, which then went on to develop really quite significant scarring. I would also like to say that if you follow some of the minimalist views about investigating following urinary tract infection, for example, in the UK, people are being recommended to follow a more minimalist view of investigation. What we've done in Newcastle is we've not followed the NICE guidelines, and we've actually audited the outcome. And please don't take any pictures of these slides because this data is currently being submitted for publication, so I wouldn't want it distributed. But what we found was that if you follow the NICE guidelines, yes, you reduce the numbers of investigations that you need to do, but you also reduce the number of abnormalities that you pick up in exactly the same proportion. So by following something like the NICE guidelines, you do fewer investigations, but the effect is like randomly picking every fourth child that comes into your office with urinary tract infection to have investigations. So guidelines like the NICE guidelines don't in fact do what we all want to do, which is to target our investigations to those children who we think are most at risk. I don't think we've solved that issue, but what I'm clear about is neither the guidelines produced by NICE nor indeed the guidelines produced by the American Academy of Pediatrics really have the answer. These are very didactic guidelines being produced without sufficient evidence, and certainly from the point of view of NICE, they were introduced with no pilot studies, no estimation of the effect, and they're proposing a complete turnaround in how we manage urinary tract infection. I'd also like to just spend a minute showing you, I talked about the evidence that perfectly normal kidneys can develop scars, and some of this comes from our work with renal transplants. We've found that adult scars that have been transplanted into children, if they have reflux and these children get urine infections, those kidneys, which you can see on the routine DMSA scan, which we do in the first 10 days post-transplant, the kidneys look perfectly normal, but following urine infection and reflux, then you can see focal scarring appearing. And yes, of course, these children are immunosuppressed, and therefore the inflammatory mechanisms going on in the kidney may be different. But I do think that this work adds some. This work does add something to the discussion about whether de novo scarring can occur in previously perfectly normal kidneys. I'd just like to finish by perhaps introducing another concept. In this study which we did in Newcastle, creating a DNA bank from families who had 2 or more affected children with vesiculoureteric reflux, what we found was that there was a very high concordance for reflux nephropathy in sibling pairs. So we know that reflux is an inherited condition, but what we saw was that if a child had reflux and reflux nephropathy, their sibling was much more likely to have reflux nephropathy. And it does make you wonder whether there is a genetic predisposition not only to reflux, but also to the development of reflux nephropathy. Of course, it may simply be that those children inherited families who didn't pick up the signs of urine infections, or they inherited rubbish doctors who didn't treat their infections, or whatever. There's all sorts of environmental factors which may be in place. But I think it's an interesting observation. So I'll just finish by saying we may not fully understand the role of reflux in UTI, in acquired scarring, but we know that acquired scarring can happen. There is some link, and I would put out a plea, let's not abandon testing, let's not abandon the children in whom there is the potential for preventing scarring just yet. So I would reiterate that following a febrile UTI, children should be thoroughly investigated, and those with VUR receive prophylaxis and active rapid management. Thank you.